is kind of increasing. It's like 26 degrees. It's approved for bladder cancer. In second line, these immunotherapies are already approved by FDA. Second line means if you have a stage 4 disease, you get a treatment in the first line, then second line you can get it as single agent. They are also approved as first line in combination with another immunotherapy or a pill. So there are different combinations called Pembro with axitinib, which I usually use. This is the first line treatment. Single agent, second line treatment. They have shown to work fabulously in stage 4 disease. And as I said, even though they work fabulously, right now we are just waiting to say when we can say it's cured. The trial, there is a trial here which is trying to look if we give one dose of immunotherapy before surgery and then continue the immunotherapy as a maintenance treatment for around a year, around 9 cycles, will it decrease the chance of kidney cancer from coming back? So in your situation, our hope is when Alex goes in, he takes care of all the cancer. But again, nothing is guaranteed. It's possible that things might come back. And this thing is, if we give one dose upfront so that your immune system gets to recognize how does the cancer look like, and after Alexis cuts down the whole cancer, and if there are any small microscopic cancer cells circulating in the body, either the immune system takes care of it or make sure they never are able to grow back. Because our immune system has a memory. So once we get an infection, it builds a memory, and that's why every year we get a different type of flu vaccine depending on what other strain might become. So that's what this trial is looking at. What it does, it randomizes people. You get to know upfront that either I'm getting the treatment or I'm getting the standard of care, that is surgery. So either you get immunotherapy with surgery or you go just to surgery. So this is an option. Just doing surgery is an option. But if I was you, I will never go for sodium bicarbonate. They look attractive, never work. It's very easy for them to show that it works. They just need maybe $2,000 investment. They need to give half of the people, just randomly let a random computer decide, give numbers to everyone. Okay, 50 of you will get sodium bicarbonate, 50 of you go to your doctor and get whatever treatment you want. Come back after 2 years or just after 6 months and show me who is doing better. They will never do it because their business will close, and that's why these people go to jail. It's very easy for them to show. They will never do it because it doesn't work like that. We give tons of sodium bicarbonate, but we have to give it with chemotherapy, and our aim is not to make the cure cancer with sodium bicarbonate. It's to flush out the chemotherapy which we are giving.
Okay.
So with it being in the lymph nodes, if you do surgery, could that you take that out too, or is that?
That's what he is hoping for, to take out all those lymph nodes.
You need lymph nodes over?
So wherever he can see cancer, he will try to remove everything. But the problem is,
How do you see cancer?
it looks abnormal when you see. So usually the lymph nodes are very small. There it looks bigger. I never did surgery. That's a good thing for you, that I am not doing the surgery. But he can tell you how it looks inside. He sends me sometimes photos after surgery, but I personally don't know how can you see everything, and
Yeah.
I'm not a surgeon. So
Okay.
I can have him come and tell you how the lymph nodes look like, but
Yeah, we've got an appointment with him here in a
Yeah,
little
at
bit.
11, yeah.
11.
I've got a quick question for you too. So with that, you're saying how the immune system blocks the receptor so that the
so
cancer.
actually, when this was found and we saw all this success,
Yeah.
and melanoma till 2011, we were using chemotherapy, never worked. People were living like less than 6 months on
Yeah.
a median, and now we are like even after 5 years, 40 to 50% of the people are alive,
Okay.
and their cancer is in remission.
Remission.
Depending
Okay.
on what study we look at, and this has led to 2 people get the Nobel in 2000, I think 19. So they were Jim Allison, who found a drug for a sister receptor called CTLA4,
Okay.
and Hokoji Honsho, who did all the work on this PDL1. He is from Japan.
Okay.
So the guy for CTLA4, he is at MD Anderson, and Honsho. So they both got Nobel last
Okay.
year for this thing.
My question with it though is, so the immune cells, so that makes it them attack the cancer cells, but what makes them not attack other cells when it blocks
Very
the
good
receptor?
question.
That's
And so this receptor is kind of the key,
okay.
because it's not on all the cells, but it's kind of an inducible receptor. So we know our brain cells have the same DNA as the liver cells. Liver cells have the same DNA as our skin cells, but the same DNA makes liver, same DNA makes lungs, same DNA makes skin, and we sequence it, we see the same DNA.
Yeah.
There are some inbuilt mechanisms in our DNA which we call as epigenetics, which turns on and off certain genes which help make these things. Then on top of that, there are many cytokines and many other signals which go and tell the DNA to make certain things. So what we think that when cancer cells get attacked by our immune system while they are growing, the cancer cells induce these PDL1 receptors as a way to survive. So it's like a fight for survival between the body and the cancer cell, which are also part of our body, but somehow they have lost control over their growth rate. So they keep on growing, and then when our body tries to kill them, they generate some signals to develop these receptors.
Okay.
Always, and as I was explaining, this is a trial.
Yeah.
So we
So
do
it's
not
not
know.
100%.
Yeah, we
but-
do not know. So in both arms, you will get the standard of care, which is the surgery. And this is something on top, and I can't guarantee that you will get to the treatment arm. It's a 50% chance. Either you get it or you not get it. And that's how we really know when something is working.
Yeah.
And that's what I was proposing to that if you really want to show, do standard and give your treatment. 10 to 15% of the time, which we know in our practice in melanoma, which I do, and I will say around 15% of the time, your immune system can get so much hyperactivated that it can affect your
Every
own
other
organ.
organ.
Yeah.
Okay.
Not every organ. So
But-
what we see, usually I see 2 main people get rash,
Okay.
or people get low thyroid hormone levels. Rarely, around 3% of the time, other organs can also get affected. Lungs can get affected, liver can affect it. So if lungs get affected, people get cough, pneumonitis. If liver gets affected, people get hepatitis, pituitary, adrenals, pancreas, kidney. I have seen all. So
Okay.
actually, I am on the guideline panel for immunotherapy in the biggest society called ASCO. I am also on the guideline panel for immune toxicities. So I have seen almost everything. So
Okay.
to be fair, we still do not know why everyone does not get side effects, why most people tolerate it very well, why a certain number of people do get these side effects. What I believe is the reason is not in the cancer, but in the germline makeup of the immune system or the person.
It's more the DNA than
More
the
the
DNA
DNA.
of the person than anything
Yeah,
else.
and-
Than the cancer, kind
Yeah.
of.
So we are still like struggling to understand why with chemotherapy, some people cruise without any toxicities, some get significant side effects thrown all the time.
Okay.
It's something different.
Can they ever
Yeah.
test it on like a smaller scale?
So it has been tested. We have published some. One of the publications I have done recently in prostate cancer.
Okay.
So what happens? We have, it's called pharmacogenomics. So it's basically, we all have different variants of what we call it germline variants of DNA, which generate different types of enzymes. Some work fast, some work slow. So if something works fast, it can quickly clear the drug. It's possible it will make the drug less effective. I'm talking about chemotherapy.
Yeah.
Immunotherapy, we are still, it's so new, we haven't reached that stage. Sometimes it works slow, so it doesn't metabolize the drug, and what happens, we see a lot of toxicities.
Okay.
So it probably comes from the genetic makeup.
Okay.
And right now we do not know how to test for it, and it will
That's
be a
what you
great
guys are
thing.
trying to do and everything. Yeah. Okay. Sounds good. Thank you for that.
So, does that answer some of your questions?
Yeah. See,
I know it's very hard. It's for what you have read, but I can trust me. I can give you 20,000 articles on it. This works with randomized clinical trials. This is a trial. This is a surgery. But in stage 4 disease, we have so many different trials which have been done in thousands of patients in a randomized fashion, blinded, independently reviewed, then reviewed by FDA, audited multiple times, and it works.
so
And-
let's say because if you do because it's a clinical trial, it's 50-50 chance you're getting the treatment. So what happens if you wanted to do the treatment? Can you do the treatment or no?
So it's not FDA approved, so insurance doesn't cover it. If you want to get, these drugs are very costly. The one shot comes to around, what I have heard, and looking at there are some blue books, it comes around 20K or something. So going by a year, it's like 240K or something. No one can afford it. So unless it's FDA approved, we cannot do it outside trial because it's beyond our pay grade. Anyone's pay grade.
So you got a 50-50 chance of going through it or not. So
But you will, in both cases, you will get the standard of treatment, which is the surgery.
yeah.
And
But-
if I start cherry picking, then I will never know what I am doing is right or not. If I give to everyone, who will I compare it with?
Yeah.
If I go to
With
the
everyone.
if I go to historical controls, they never got the standard of treatment. We have so many new medications.
They have to have that standard.
Yeah. So in my view, this trial gives you a 50% opportunity to get a treatment of the future.
Or 50%
Chance
chance
of
of getting shit.
It's not shit. It's
Well,
it's
You
still
get shit.
theoretically can
You
cure.
get the surgery
And
no matter
if you-
what, though.
yeah.
Yeah, it's not that you are not getting it. You get the standard of what is FDA approved, or you get another medication on top of it, which might or might not benefit. We do not know.
Could be chemo, or it could be something else.
It's immunotherapy.
Immunotherapy.
It's this thing. It's not chemo. Chemo doesn't work in kidney cancer. Yeah, with the normal clear
I
cells.
can't see my body making up bad cells. Why they would all of a sudden start mutating bad? Except
It's ask your body.
except to protect the other cells.
So that's a very good thing.
like a scab.
So let me tell you. So every year millions of mutations go into our body, and we have inbuilt ways to correct it. And almost all mutations get corrected. Even if there are some mutations, they will not be corrected, but they don't give growth advantage to the cells. Rarely one mutation gives the growth advantage. How we develop those mutations? There are a variety of factors: age-related, oxidative stress, exercise, sun rays, food we eat. Everything is this, and that's why our body has all these DNA repair mechanisms. It happens. So you just, in millions and millions of these mutations, maybe one mutation goes uncorrected, and that cell escapes the immune system, escapes with whatever our inbuilt mechanisms are, and just grows. And then it makes 2, 2 makes 4, 4 makes 8.
And they start splitting.
Yeah. So now that's what I had to say.
Okay.
And
Okay.
my throat is.
No worries.
Let
a
me
lot.
listen to.
You're probably busy. Oh, you gotta go or?
I am to listen to heart to lungs.
Okay.
See my. So, any other questions?
No, that's got a lot of it.
Yeah.
Yeah.
Think about it.
So I need to talk to Sanchez and then
Yeah, if you
and
want
get
to participate in the trial, let Sanchez or me know. If you want to go with the surgery, let me or Sanchez know. I will never
that's
ever.
removing the whole kidney and then the lymph nodes.
Unfortunately, that's the
I
standard.
think the
of
lymph nodes have to come out no matter what.
Yeah, if they look cancerous, they need to come out. So that's why we got it. But
Kidney
no
can't
matter
stay.
what, I will not say to go to this sodium bicarbonate. It
No.
will be very bad decision. I know it hurts to hear.
Yeah, but I still want to try something that's not going to be attacking.
What?
You know what I'm
Why
saying?
don't you do one thing? After you go through all these things, then you go and get some additional sodium bicarbonate or whatever you want.
Because this may be the answer to before having all this done. You know, well, he even told me over there. The doctor over there. He told,
Even
he
the
told-
standard of care is this thing, surgery.
Yeah, well, he said there didn't need to be surgery on the lymph nodes. He said that would need to be done for sure. But he was talking, on the also on the kidney that, some sodium bicarb directly on that to try to get some shrinkage of the tumor, and but before surgery on it, just to try to get it from the blood vessels, I guess, coming away from it. Yeah, something like that. Yeah, but
It won't work. I am saying it's being recorded.
okay.
You can quote me on it. It won't work. That sodium bicarbonate thing, if it would have worked, and till now everyone would have been starting it with sodium bicarbonate. It will be the standard that we will give sodium bicarbonate, we will do surgery, and 50% chance we will give this immunotherapy or not. Then that would have been the standard. So, but if the cancer moves somewhere else, then from stage 3 it becomes stage 4.
Well, that's what they already told me I'm in stage 4.
If it moves somewhere else, then it becomes incurable. Theoretically incurable.
Because it's in the bloodstream.
It likely is still in bloodstream, and that's why this trial is being done. But if it goes somewhere else, then probably we will go with standard of the treatment, which is here at the bottom. So yeah. So, and that's a whole different discussion. And there I don't say that.
See,
Then I start talking about the response rate and the disease control rate. I don't say there is a possibility. Here, there is.
see what right now what I'm seeing though, in 5 years I got an 8% chance of living in 5 years.
You do not know. Let me show you this thing. I don't know where you are getting this number. Who told you 8%?
I mean, I've looked it up online too, and stage 4 is 8%.
It was, so that comes from CA data, and it's quite old. Renal cell. Let me show you the latest data. GUSCO.
Renal cell personal.
So GUSCO 2020. So This is the latest data with this new immunotherapy. So you are getting this one in the trial. This is here, it is combined with this drug with another drug which BMS makes, which targets this receptor, which has more side effects. So that's how here we give treatment, or we give standard of care. In this case, it was a pill. You can I can print out of this thing, but you will find many of these if you Google, click a photo of this thing.
Zoom in on that.
So this came out last month. Okay. So this trial, it took patients with clear cell renal cell component who didn't receive treatment, and then they all were first line poor or intermediate risk renal cell carcinoma, and they were advanced, meaning either you cannot cut it, it's came back at the same thing and you don't have treatment,
Yeah.
or it has metastasized. And when they received this treatment, here at they said, okay, let's look at 42 months. You see 52% of the people are still alive, as compared to 39% who received standard of care. In this case was a pill called sunitinib.
Okay.
So at 42 months, 42 weekends,
So we got 48,
24,
and we got 50. So at 50 months
still
is 5 years. Well,
60 months.
60
60.
months.
So it's
actually,
42,
right at
it's
the end
like 52%. And now, as you are seeing, the curves are kind of flattening because immune system is something very powerful.
there. Okay. Well, you got to see my point. I mean,
I am seeing your point, and
when
that's
somebody
why-
else tells me or is saying, you know, that
So-
that I could lead basically a normal life if I try there, and that's why I can't see why not try. I mean, it's.
Because he's telling a lie.
But I haven't seen nothing bad about him except for stuff that's made up.
You
I
go
mean,
on
you know-
Wikipedia, at the bottom there are so many references which points out to all the news. You click on those references and you see what those news report. So these news are from different news channels,
Okay.
BBC or whatever, Independent or all those things.
Okay, let's look at MIT study. MIT did a study. with-
MIT is not a hospital.
Yeah, but MIT, their scientists did a study there with cancer cells that were put into mice and used sodium
In mice?
bicarbonate.
In
Yeah,
mice?
I know it's different. It's different. It's a different animal than us, but you can't to do that's. There is no clinical studies with sodium bicarbonate on
Yeah.
people.
We give sodium bicarbonate left
But
by
okay, how do they do that though? I mean, if there hasn't been no clinical trials on it.
it didn't work. People have, and it's very easy for them. If it's so effective, just give it to people. Just say that, okay, randomly 50 people I am giving my treatment, 50 people
Yeah.
get standard of care. That's what this trial is doing. No one is stopping them. For 50 years, 60 years, 100 years, stop making fool. You have a potentially curative disease. Why you want to make it incurable? It's your choice.
I
ultimately
don't
it's
want to
your-
make it incurable.
But you are.
But see, from what I've been just looking at this, it is incurable. I mean, you know,
This
it's,
is something which is incurable. As he was quoting out the numbers, 8% of those, these new drugs, people are living this much. This is a clinical trial. Last year, it became standard of care in first line setting for intermediate and poor risk people. FDA approved this thing as the first line treatment.
so where flat lines out there, is that the end of the study? I mean, that's
No,
from where the study started, or?
So this is where the study started. We have reached till this point.
Okay.
As time will pass, we will get more results.
Okay.
This is
But-
where they're at now.
But now,
Some point
I
you
even
can
don't
go up.
give this. I give another treatment which is kind of looks more effective to me. Where immunotherapy is combined with a targeted therapy. So I even don't give this because there is another thing which is FDA approved.
which is better.
But still, I don't say, even with this, right, we don't say it's curable.
Okay.
As you said.
And is that stage 4 then?
It's advanced, so like either it's stage 4 or something
advanced.
which cannot be resected.
Okay. So where he's at, he's not even at that point yet then.
He is not, but he can be if he continues
To wait.
ichlytube.
Yeah. Okay.
Well, I think that.
How fast is it? Does it?
And now he is trying to.
How fast does it spread? I mean, would it keep
Oh,
growing?
that I don't know
It's
because
different by
what
the
we have
person.
just a snapshot. We knew probably in 2014 he did not have it, or it was so small we cannot see it. I do not know whether it grew over 6 months, year, 2
Okay.
years. There's
5
no
years
reports.
kind of thing.
Yeah.
Yeah, I don't
I
know.
didn't know if you could tell or not.
No, it's
Like if it gets rings like a tree.
after surgery we keep on doing the scans in either scenario, in trial or. and
Right,
we can
right,
all
yeah,
discuss.
yeah.
Okay. I know you're busy, man. You got other people to see. I thank you for your time. And so
Thank you.
we'll go see
Dr. Sanchez and-
Sanchez, and then we'll go. Yeah.
Okay.
Thank you.
Thank you so much for your
Thank
time.
Yeah,
Thank you.
I appreciate your time. Thank you.
Thank
Thank
Share
you.
some light on things.
Do you need campus or?
Right now we can.
What is that?
Thank you.
So we do some genetic testing and all those things on the tumor and the blood to see if there are some mutations, if
Okay.
you want or if you don't want.
Is that blood work I already did this morning?
So we took it, but we don't have to submit it. So he doesn't necessarily need it right now, but
If you
you're
want, we can
interested-
do it
Yeah.
and we will have the results. So
Might as well. I mean,
yeah,
yeah. Is that all right? Yeah.
yeah.
And then
So
So we don't have tissue yet. but-
so tissue, if we decide for a surgery.
when we did the biopsy,
And
would that be
biopsy.
tissue?
Yeah,
Yeah.
I have to see how much tissue is there, but
Okay.
first we go for. Okay.
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 Alright.
Thank
Thank,
you.
Thank you.
Appreciate your time. Thanks.
Have a good one.
Help him make the right decision.
I'll try.
Okay, so with this, it's, the company's
For
called
me?
Tempest, it's
I
a
don't like
genetic
those.
testing
I always have to spit
company.
out that.
Okay.
So we
The
have the
shell
blood
of it.
that we took from this morning, and then they'll take a sample of a tissue that you have out there. So you did
Is that
get a
Karen?
biopsy done sometime before or?
Last
Yeah,
Friday.
Friday? Oh, okay.
Should be here soon then.
Mhm. They had already started checking out the
Yeah,
cells,
I-
they
I
said
thought-
before we were
yeah.
leaving. I'm
I
like,
thought
okay.
maybe they were gonna, Dr. Swami there was gonna discuss that on the biopsy.
Well, and Mr. Dr. Sanchez may have that.
Yeah, you might have that stuff.
Or
It was
some.
done at the Huntsman or the U?
Yeah, yeah, Huntsman.
Okay, perfect, I can find it then. So if we have you fill out this financial application form, they guarantee it won't be more than $100 to run the testing. So if you're okay with that, I just need a signature.
Okay.
And.
Do I need to fill this one out or?
Yeah, so I'll get a signature on this one saying we're okay to take your sample and
I
test it.
didn't bring glasses, so,
Sign right here.
you know, oh, you just need me to sign it?
Yeah, I just need
Okay.
a signature
I
saying
can
we're
fill out
okay
the other
to.
one right
Where?
there. So like I'm gonna start right where my finger starts.
Okay.
Okay, and then this is the financial application form, so if you
I
wanna,
can fill
someone,
that out.
yeah. I'll take this, thank you.
Eight,
Good on this?
Yeah, wait.